Hello, this is again Professor Nick or PA Nick or Triple Nick from Brooklyn, New York. I would like to introduce you my next lecture from J series. It is about small intestine and colon. Let's start from the first slide. This slide discusses small intestine in colon, the malabsorption syndrome. The clinical tip here is that fat malabsorption frequently presents with weight loss. And another clinical tip is that vitamin B12 needs intact bowel wall and pancreatic enzymes to be absorbed. Malabsorption is related to the celiac disease, which is one of the most common type of malabsorptions and can be presented in adults. Chronic pancreatitis has a very similar presentation with fat malabsorption. Rare causes for fat malabsorptions are tropical sprue and Whipple disease. All of this presents with steatorrhea, defined as a stool which is oily, greasy, floating and foul smell. All forms of fat malabsorption presents with deficiency of fat soluble vitamins like vitamin A, D, E, and K. And on the right side of the slide, we have different vitamin D deficiencies and clinical and laboratory manifestation, laboratory and clinical manifestation. If we have a deficiency of vitamin D, we have hypocalcemia and osteoporosis. This is number one. Number two, if we have vitamin K deficiency, the manifestation is bleeding and easy bruising. And if we have vitamin B12 deficiency, we have the patient presents with anemia, neuropathy, and hypersegmented neutrophils. Let's go to the next slide. Slide number 3. Slide number 3 discuss tropical sprue and celiac disease. There is nothing clinically which can distinguish tropical sprue from celiac disease or gluten sensitivity, sensitive and enteropathy. Cardiac disease, celiac disease gives dermatitis herpetiformis in 10% of the cases. And this is like a clinical tip. So celiac, let's repeat, celiac disease gives so-called dermatitis herpetiformis in 10% of the cases. Let's talk about Whipple disease. Whipple disease can present with arthralgias, ocular finding, neurological abnormality as dementia, seizures, fevers, lymphadenopathy, and can be treated with ceftriaxone followed by Bactrim. Diagnostic test for this is usually one of the main differentiations between chronic pancreatitis and gluten sensitive enteropathy is the presence of iron deficiency. This is because of iron needs an intact bowel wall to be absorbed, but does not need pancreatic enzymes to be absorbed. Let's go to the next slide. Slide number 4. Celiac disease there is some unique test for celiac disease. This is the first test is anti-tissue transglutaminase. Number 2 is anti-endosomal antibodies. And number 3, IgA, anti-guanine antibodies. The most accurate diagnostic test for celiac disease is a small bowel biopsy, which usually shows flattening of the villi. Whipple disease and tropical sprue are also most accurate diagnosed with bowel wall biopsy, which shows specific organism. The clinical tip here is that bowel biopsy is essential in celiac disease to exclude lymphoma. Let's go to the next slide. Slide number 5 talks about lactulose intolerance. No weight loss usually when you have case of lactulose intolerance, because the lactose is the only one of several sugars which is absorbed. Lactose intolerance does not alter the absorption of any other nutrient such as fat, so there is no deficiency in calories. Usually the vitamins are absorbed normally. The stool osmolarity is increased, but the usual way to make the diagnosis is simply to remove all milk-containing products from the diet and wait a single day for a resolution of the symptoms. We need the patient needs to avoid milk products except yogurt, and this is the therapy. Using oral lactulose replacement is also good therapy and is available over the counter. Let's go to the next slide. This slide discusses so-called irritable bowel syndrome, or IBS. IBS is a pain syndrome which is associated with diarrhea, constipation, or both. There is no specific diagnostic test, and it is diagnosed of exclusion in association with complex of symptoms. IBS is not associated with weight loss. Pain does not automatically mean malabsorption. The pain in IBS is, number 1, relieved by a bowel movement, number 2, less at night, and number 3, relieved by change in the bowel habits, such as diarrhea. There is a clinical tip here that IBS is not associated with blood or white cells in the stool. Let's go to the next slide. This is slide number 7. The treatment of IBS. Number 1, we need to have fiber in the diet. Number 2, we need to have antispasmodic agents such as dicyclomine or hyoscyamine. Also, we can give the patient tricyclic antidepressants, example aminotriptyline or SSRI. Additional therapy for diarrhea predominant IBS includes number 1, rifaximin, which is a non-absorbed antibiotic with modest effect in diarrhea predominant IBS. Number 2 is avosetron, which is inhibitor of serotonin with modest effect in IBS, and you need to have special permissions to use it. Number 3 is eluxadolin, which is mu opioid receptor agonist for the diarrhea IBS, which relieves the pain and slow the bowel. And number 5, this is probiotic. It's unclear the mechanism of action, and so do not choose it as an answer. Additional therapy for constipation predominant IBM. This is fiber, number 1, fiber. Number 2, PEG, which is polyethylene glycol, which is not absorbed by lubricant. Number 3 is lubiprostérol, which is chloride channel activator. You can use it if PEG does not work. And number 4, this is lunacotide, which is guanylate cyclase agonist, which is used if PEG does not work. Let's go to the next slide, slide number 8. On this nice table, there is a differentiations between CD and UC, which means Crohn's disease and ulcerative colitis. Crohn's disease, you have 5 very important features. There is skip lesions, there is transmural granulomas, there is fistulas and abscesses, there is masses and obstructions, and there is a perianal disease. In ulcerative colitis, it's curable by surgery, is entirely mucosal, there is no fistulas or abscesses, there is no obstructions, and no perianal disease. Frequent question is, when should screening occur? The answer is after 8 to 10 years of colonic involvement, and it's done by colonoscopy every 1 or 2 years. 1 to 2 years, sorry. Let's go to the next slide, slide number 9. This slide discusses diagnostic tests such as ANCA or ASCA for IBD. We need to know that diagnostic test is endoscopy is the most accurate test when the disease cannot be reached by a scope. For CD, that is mainly in the small bowel. Also, radiological tests such as barium studies will detect the lesions. When the diagnosis is still unclear, serological testing may be helpful. All IBDs are associated with anemia. So let's talk over table on the right side of the slide. ANCA on anti-neutrophil cytoplasmic antibodies. It's negative for Crohn's disease, and positive for ulcerative colitis. ASCA or ASCA, anti-Saccharomyces cerevisiae antibodies, is positive in Crohn's disease and negative for ulcerative colitis. Let's go to the next slide, slide number 10. The treatment is kind of complicated, but let's talk about this. Acute exacerbation of the disease can be treated with steroids in both CD and UC. Chronic maintenance of remissions is usually treated with 5 ASA derivatives such as mesalamine, Asaco or mesalamine is used for UC, pentase or pentase, which is again mesalamine is used for CD. Rovasa, which is also mesalamine, is used for UC, which is largely limited in the rectum. Steroids which are used are usually prednisone or butenozolone. Also, we need to note that azathioprine and 6-mercaptopurine are used to wean patients from the steroids when the disease is so severe that severe recurrences developed with steroids are stopped. Everyone needs calcium and vitamin D. We need to know that perianal CD is treated with Cipro or ciprofloxacin or metronidazole. Also, we need to know that fistula and severe disease unresponsive to other agents are treated with TNF agents such as infliximab. Surgery is done when the fistula is presented only and there is no response on anti-TNF agents. Neither form of IBD is routinely treated with surgery. UC can be cured with colectomy. In CD, surgery is usually extensively for bowel obstruction. CD will tend to recur at the site of the surgery. If the disease is refractory to all other treatment, give vedolizumab, which is alpha integrin inhibitor. Butenozide is a steroid specific for IBD. This is a clinical fact. First pass effect is good for EBD treatment. Let's go to the next slide. Slide number 11. Let's discuss diverticular disease. Diverticulosis means it's when you have outpouching of the colon, which are so common on the standard meat-filled diet as to be routinely expected of everybody which is 65, 70 and above. Vegetarians rarely develop diverticulosis. Diverticulosis is symptomatic mostly of the time. Patient may be presented with the left lower quadrant pain, constipation, bleeding, and sometimes infection. Diverticulitis. The most accurate test is colonoscopy. Barium studies are accepted but not as accurate. Bran, phenyl, methylcellulose, and increased dietary fibers are used to decrease the rate of progression and complication. Diverticulitis is the most likely diagnosis question and can be easily answered when the patient is presented with one of the following: Left lower quadrant pain and tenderness, fever, leukocytosis, palpable mass sometimes occur. Symptoms such as nausea, constipation, and bleeding can be presented, but are too non-specific to be useful in establishing of the diagnosis. The best initial test, this is CT scan, colonoscopy, and barium enema, this is a clinical tip, are dangerous in case of acute diverticulitis because of increased risk of perforation. The infection weakens the colonic wall. And let's go to slide number 12, the last slide. The treatment for diverticulitis is with antibiotics, which cover E. coli and anaerobes, and they are presented in the bowel, such as Cipro, fluoxetine combined with metronidazole, or beta-lactam, beta-lactamase combinations such as augmentin or amoxicillin clavionate, ticagrelin clavionate, and or piperacillin tazobactam, also with carbapenem surgery, carbapenem or entrapenem. Surgery is answered when you have no response to medical therapy, frequent recurrence of infection, perforation, fissures, abscesses, strictures, or obstruction. Who is the mostly likely to get a recommendation in the surgery, young or old patients? Younger patients should have a colon resection more often because of the greater total numbers of recurrent episodes. Diverticular disease does not disappear despite treatment episodes of diverticulitis or the use of fiber in the diet. Patients with acute diverticulitis should not be fed. And this is the end of the lecture. Again, this is Professor Nick, or PA Nick, from Brooklyn, New York. If you have any suggestions or recommendations, please feel free to email me at the following email, Nick, Nick, M like Mary, D like dog, the number 1, @gmail.com. Thank you.